Number one, true or false? Mild sleep apnea doesn't need treatment if you're not sleepy during the day.
False.
Number two, can low testosterone or secondary hypogonadism be caused by poor sleep or untreated sleep apnea?
Yes.
Number three, is it true that only people who have weight gain or have a BMI in that overweight or obesity category get sleep apnea? Today, I have a sleep medicine specialist. Yes, I know many of you didn't even know or were aware of that in medicine, we have a specialty called sleep medicine. And I am very delighted to introduce you to Dr. Funke Brown. She's a Penn-trained sleep medicine physician with over a decade of experience. And I'm so excited to ask a plethora of questions. Let's see how much we can cover in today's episode. Welcome, Dr. Brown.
Thank you so much for having me, Dr. Makhija.
So, Dr. Brown, for our audience who are listening as well as watching this video, please elaborate on sleep medicine as a physician, as a specialist, and tell us how you help people and how you help your patients.
Yes. So typically the way it works, we get in a training, an expertise in sleep medicine. It's an additional training. So most of us would have done like a primary training. So for me, I did two. I started off with pediatrics. So I'm trained in pediatrics. And then I'm also trained in pediatric pulmonology. So these are people who have breathing issues. And so I decided to go to do an additional year of sleep medicine where we take care of both children and adults with sleep problems. And then, so the way my practice works is I see both children and I see adults, but it's the pediatric piece is a very, very small niche. So there are not many people who do pediatric sleep medicine in the world, actually. So I get to do that, but my training encompasses both adults and kids.
Wow. So you've had your medical school and then residency in pediatrics and then pediatric pulmonology and then another board certification for sleep medicine, including adults and pediatrics. That's extensive. And then comes your clinical experience. Impressive. So in just clinical world in practice, how are you incorporating this before we get into our deep dive questions and rapid fire questions?
Yeah, so I have I would say what's called a sleep and wellness practice. So we're really looking at sleep holistically. When you go out there, you might have people who only focus on maybe sleep apnea or people who focus on maybe just insomnia. So I do all of that, but I do it in the scheme or, in relation to the entire well-being of the child, of the adult, of the family. So we're looking at like some of the things you do, which I think we've collaborated. I've talked a few times about, wait, I have this person who looks like impaired glucose. What do I do? How's their sleep impacting it? So we're really looking at things very holistically in our practice. And so we're not just kind of giving you a CPAP machine or telling you to get out of bed. We're really looking at what's your exercise like? What's your diet looking like? How do we optimize your bedroom? How do we set boundaries for you to be able to get the sleep you need to thrive? How do we help you be a better parent to teach your child how to sleep so that you can get the sleep you need? How do we get your pets out of the room so that you can get the sleep you need? So we're looking at this very, very comprehensively.
Yes. So, this whole person holistic approach that where medicine is actually heading towards. Amazing. So, Dr. Brown, we have a few rapid fire questions for you. And these are either one liner answers, yes and no, or true or false. And then we get into our deep dive questions. So, here we go. Number one, true or false? Mild sleep apnea doesn't need treatment if you're not sleepy during the day.
False.
Number two, can low testosterone or secondary hypogonadism be caused by poor sleep or untreated sleep apnea?
Yes.
Number three, is it true that only people who have weight gain or have a BMI in that overweight or obesity category get sleep apnea?
False.
True or false again? You can catch up on lost sleep over the weekend.
False.
Is snoring always harmful?
True.
Does screen time before bed affect sleep quality?
True.
People, this is for everyone. The last one,
Mhm.
what's one myth about melatonin you wish people would stop believing?
That it cures insomnia. It doesn't.
Sweet. Thank you so much. So now I'm thoroughly excited to get into the deeper case like questions. So in endocrinology, I get a lot of referrals for secondary hypogonadism. I'm being very specific where testicles are not at a problem, it's something else systemically. Most of the times, in these young individuals, I'm talking between, say, 30 to 55-year-old men who shouldn't have that low for testosterone. When I do the entire evaluation, most of them tend to have this diagnosis of a mild sleep apnea on a home sleep study. And when I refer them locally to, say, their primary care physician or a dentist, it's like, ignore it. It's mild. You're not having any symptoms or specific diseases, but I have this metabolic finding, right? We have this hypogonadism. So, in your practice, in your clinical world, and for our patients and audience, so anyone with mild sleep apnea, how is it connected to secondary hypogonadism? And the second, what are the strategies and approaches? I feel that it should be treated, it can be prevented. So please share some insights here.
Yeah, so mild sleep apnea or mild, some people will call sleep disordered breathing. Or first, sleep apnea in and of itself is when you have pauses in your breathing during sleep. Oftentimes, people present with snoring, some fragmented sleep, unrefreshing sleep. Many people have daytime sleepiness. Sometimes people don't have daytime sleepiness. And some of the reasons is because maybe they've had long-standing sleep apnea and they've just become so used to that baseline that they don't even know what their daytime function is supposed to be or what's normal. Typically, you make a diagnosis of sleep apnea based on a sleep study. A sleep study can be done at home. It's called a home sleep test, or it can be done in the lab. It's an in-lab study. And then we grade the severity of sleep apnea based on the what we call an apnea hypopnea index, meaning the number of times you have full pauses or partial pauses over the course of the night, and it's divided per hour. So an AHI or apnea hypopnea index of less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and greater than 30 is severe. In addition to that, you're looking at the oxygen level. So remember, we said you have pauses in your breathing. So that pauses in your breathing is causing a lot of impairment. What are the impairments? Number one is if you're not breathing, you're not getting oxygen. And oxygen is life. So you're getting intermittent shortage in oxygen getting delivered to your heart, getting delivered to your brain, getting delivered to your organs. And so as a result of that, it does cause significant disruption. Now, what we've seen is some people have noticed that if you have more severe sleep apnea, you might have more severe consequences. But we also have, especially with women, and other people, that even mild symptoms and mild sleep apnea can also result in significant impairments, such as a decrease in testosterone. And the way that works is, I'm not the endocrine expert here, but we do know that when sleep is fragmented, you stop breathing, oxygen is cut off, your brain sort of goes into this fight-like response. It increases your cortisol level. It might wake you up. When you have that sleep disruption, it affects that pathway, the pathway where the testosterone is produced, the hypothalamic pituitary adrenal axis, that HPA axis. So that's one of the ways. Another way is, remember, we talked again about, blockage and interruptions in oxygen. We call it intermittent hypoxia. Because you're not getting that direct oxygen feedback loop to your brain and all to the essential organs, over time, it can directly decrease the testosterone level. And of course, in moderate to severe sleep apnea, you get even more of a significant decline. So there is a very strong association, I would say, not even just sleep apnea, but even also poor quality sleep overall. So because of that, I think it is important that we don't just take it lightly. And then the other piece I would mention is when you do a home sleep test, it actually oftentimes underestimates the severity of your actual sleep apnea, which is why sometimes if we have people who are very symptomatic, they get a home sleep test, it is recorded as normal, meaning that it doesn't show sleep apnea. We typically will still recommend they get a repeat study or that they get an in-lab study, which is much more accurate.
Wow, there's a lot of insights here. So mild, moderate, severe, and then based on the index. With that, I have a question. So, for us in general, right, for clinicians, the reliability of home sleep study rather than the in-lab, because there comes, accessibility, trying to get it approved through insurance versus home sleep study. It's more convenient. Patients are in there in their bed, in their homes, in their bedrooms. So that kind of mimics the natural phenomena of their routine. Is there a preference, or is it like, let's just start with home sleep study, and then if there are doubts or questions or inaccuracies, then move on to the in lab?
Yeah, exactly that. So typically what we do, because access is an issue, of course, insurance plays a big role in all of this. So, and as a result, the home sleep test is actually the first line test that's done in healthy adults. Right now, it's not FDA approved for children under 18. And so you get that home sleep test first. And in most situations, again, if you have an otherwise healthy individual, you really are able to get the results you need. And some of the technology with the home sleep tests are becoming more advanced. Some of them actually now have EEG profiles, which can actually help you look at the brain waves so you can see that someone is asleep or someone is not asleep. With the standard one there, if you have someone who has insomnia or sleeping difficulties, sometimes they may lay very still that the machine actually thinks they're sleeping. And so this is where the underestimation may come in, right? So this is really where the issue starts to be. And so with the in lab, you get a lot more accuracy, but I would say probably 80 to 85%. Don't quote me on that. I would have to give you a reference to say for certain. Most times that is tends to be sufficient. Now, if you have somebody who has any circulatory problem, you have somebody who has a history of congestive heart failure, you have somebody who has maybe COPD, who has, maybe during the day they have severe lung disease, in those kind of individuals, you probably want to just go straight to do an in-lab study, again, because you might not get an accurate reading.
Okay. What about, indications for getting a home sleep study? So other than us being suspicious that, oh, these symptoms sound like they could be relevant to mild or, concern for sleep apnea, or, there are symptoms that need to be evaluated. But say if there are other sleep disorders, can that qualify to get a home sleep study? And would that be helpful for making a diagnosis, or at least gearing towards where should we head?
Yeah, the primary indication for a home sleep study is to rule out sleep apnea. That's it. If you have concerns about other sleep conditions, then that's where an in-lab study would be preferred. So if you have concern about restless leg syndrome, or periodic limb movement disorder is what we call it. If you have concerns about what we call nocturnal seizures, some people have some seizure-like activity. If you have some concerns about maybe narcolepsy, and so that's a test that you need to do in lab, where you do the overnight sleep study, and then you do what we call a multiple sleep latency test or NAP test during the day. So in those kind of situations, then an in-lab study is the first thing. You don't stop with home sleep test at all. But if you're really looking, does this person have sleep apnea or not? Usually a good sleep test is oftentimes sufficient to give you that answer.
Okay, so this is, a very valid reason. And I also wanted the audience to know that as we, head into the next discussion, that it is very true, like the way I describe it to patients or even my students, that, there is this fight and flight response going on in our system where the sleep is disrupted or impaired or fragmented, or there is sleep apnea. And that leads to what you just described to us as the hypothalamic pituitary gonadal axis suppression, because we don't need our reproductive hormones for a fight and flight response. So they dip down, but we need other hormones for that fight and flight response, which is the cortisol. And that gets stimulated. And the same thing with glucose or adrenaline. They get higher. And that's where we have this fasting levels of high cortisol, fasting levels of high glucose, and low levels of testosterone or subnormal levels of testosterone. So thank you for actually explaining what's exactly happening in the brain and our entire body. So with that, can we advance into again, I'm really into trying to figure out our patients with mild sleep apnea, because we have a more legit guideline-based treatment for moderate or severe when they're CPAP indicated. But what are your clinical strategies, tools, or discussions that you implement for your patients in regards to mild sleep apnea, not very symptomatic, maybe mild fatigue, and some may have this low normal testosterone, or in women, they just have this sense of fatigue?
Yes, great question. So I think right there is the key, is really looking at the patient in front of me. There's a reason why they came to see me. They may have come to see me because they feel tired all the time, right? And maybe they were referred by an endocrinologist because they have low testosterone or something, or an abnormal hormone profile, or they have difficult to treat hypertension, or they're struggling to lose weight, or they're depressed, or maybe they're not super sleepy during the day, but they're just fatigued all the time. So that is what drives my decision when it comes to treatment. Have you ever had somebody show up and say, I have no symptoms, I'm just curious? So most times people are coming because something is going on, something is out of the norm. And so when I get a mild phenotype in that sense, or mild apnea hypopnea index, but I have somebody with any of those symptoms, and I'm not waiting for 2 or 3 or 4 of them. Like, I just need you to tell me, I'm tired, I got a sleep study and it's showing sleep apnea, and I have a hard time getting out of bed in the morning. Or I've been struggling with getting myself off this 2 or 3 hypertension medications. That right there justifies being as aggressive as I would be as somebody who has moderate or severe sleep apnea. And so in terms of the treatment, and this is a collaborative conversation. So it's not really about just pushing CPAP on everybody, but trying to see what works for you or works for your lifestyle, and things like that. So starting from CPAP, that's the one that's been around the longest. It's kind of like the gold standard for treatment. It's continuous positive airway pressure therapy, where you have a device, almost like a compressor, that pumps air through a tubing into a nasal mask, full face mask. There's such a wide array of masks. And I think I want to just get this out there. A lot of people are hesitant because don't want to look like Darth Vader. You do not have to look like Darth Vader anymore. There's such subtle, classic, elegant looking masks, even for women, that you can use. And I think it's really that relationship between getting the right mask fit that really makes or breaks that CPAP or sleep apnea treatment journey. So that's number one. And we work very, very closely. We work very closely to find the right mask. We do some motivational interviewing. We do a lot of behavioral coaching to make sure that they're able to tolerate CPAP. So if you decide, you know what, CPAP is not for me, I don't want to have anything to do with it, that's fine. The beautiful thing is there's so many other options. Another option is oral appliance therapy. So these are fabricated. This is not the night guard that you're getting from the pharmacy or from Amazon. These are specifically designed for you, usually by a sleep or airway dentist, that is fabricated to move your jaw slightly forward to create a more patent airway. So we would work with that dentist. We will send them your sleep study. We will send them our recommendations. They will fabricate it. Usually I have my patients come back to repeat the sleep study to make sure things are better. And so they make adjustments based on that. And this is transformative for many people as well. In fact, there's some people who have severe sleep apnea that they need very, very high CPAP pressure, that we also include the oral appliance so that they don't need very high pressure, that we can drop the pressure. So oral appliance, readily available, very effective treatment modality. The third, I would say, in the situation where there's mild, sometimes we'll do, especially even in children as well as in adults, we work with orthodontics. So one thing we know is that the roof of the mouth, right, is the base of the nose. So you do need a patent nose to be able to breathe well at night. So working with orthodontics, we have some what we call palatal expanders that expand your hard palate to create more room so that you're able to breathe well through your nose and things like that. So this is something, it does take some time. In this situation, you're working more with what we call as an orthodontist, a sleep informed orthodontist. So not just anybody that does braces, but somebody that's very aware about how the airway interacts with our sleep and our breathing. So that's another treatment option. And then, there are other things like positional therapy. One thing we know is most times sleep apnea tends to be worse when we're laying supine, when we're laying on our backs. So what you can do is create, and we have different devices, and you could kind of bootleg it and do it yourself at home. You could spot, an old t-shirt with maybe tennis balls or put it in a fanny pack, and you wear that. And the goal is to make sure that you're not laying on your back while you're sleeping, that you constantly on your side. So that kind of helps ensure that your jaw and your tongue doesn't fall back to block your throat. So that's another viable treatment option. And then there's myofunctional therapy. can think of that as the gym for your upper airway. So these are exercises. So typically you will do this with a speech therapist who has specific training in myofunctional therapy, and they literally teach you to exercise the muscles um, of your upper airway, the muscles of your throat, the muscles of your tongue. And so with that, as that, it's almost like going to the gym, then your airway is less likely to feel so fluffy. And so that's also a treatment option, especially if you're more in the mild category. And then finally, I will think about things like, of course, weight loss. So that's actually one of the bigger ones. That's good cause, right? Because excess fat in the tongue, excess fat in the neck contributes to sleep apnea. So weight loss will decrease the severity of sleep disorder breathing. So if you're within that obesity or overweight range, I think losing some weight will absolutely help.
You talked about a lot. Let me just summarize and please correct me if I miss anything. So, the first thing you said was CPAP, if that's indicated, or if available and patient is okay with comfortable using it. And there are so many other ways of using the CPAP. And then the second one was the mouth appliances or the oral appliances, which are more custom made. The third was the orthodontic referral or working with them in collaboration to help get them an expansion. The fourth one was, I think I remember functional, but before that was some support or positional, what you talked about, right? And then the fifth one was the functional aspect of basically working out your mouth or your facial muscles to help with treating the sleep, right? It's almost treatment. Okay. And then last one, yes, the weight loss. I wanted you to please shine some light specifically for sleep apnea. The difference is that it is not necessary that every person who is heavier has sleep apnea. It could be diagnosed in any BMI category.
Absolutely. Obesity is just a risk factor. It's not the cause of sleep apnea. It's a risk factor, right? But we have a myriad of people. We have people who are underweight who have sleep apnea. There are many things that can cause sleep apnea. The bottom line is your airway, for some reason, is either a little bit crowded or it's just not open enough. So, anatomical variations. So, for instance, if you have a flatter face, if you have a mildly recessed jaw, if you have people, again, who have maybe nasal septum deviation, if you're, you really don't necessarily, in fact, you might not have any of those and still have sleep apnea. If you have more of just the lower, more relaxed tone in your upper airway, and I see this with women in perimenopause and menopause and all of that as well. So and then if you have just low tone, some people just have slightly lower tone overall. And so they may be at risk for that. And then another thing is, well, more in children, but even in some adults, if you have big tonsils or what we call big adenoids, tonsils are the tissues at the back of the throat. Sometimes that gets enlarged and that will crowd that airway. So if we can think of anything that makes it hard for that airway to stay wide and open during sleep, that can put you at risk for sleep apnea.
Wow. Okay. So, my last question relevant to sleep apnea would be in these mild cases again. Say if there is a risk factor, which is obesity or overweight, and they are currently being treated for mild sleep apnea. Have you seen patients reverse their mild sleep apnea because they have treated their risk factors?
Absolutely. Which is why really that's one of the philosophies we have in our practice is really about root cause. Of course, you may want to use temporizing measures because somebody's struggling, they're hardly functional, they're tired during the day, they have high blood pressure and all these risk factors. So we want to treat it, but really still making sure you're addressing the root cause. So depending on what happens, I've had people go and get, their nasal septum fixed. Again, I've had people who have worked with the orthodontists to create more room in that airway. We've had people who have been put on, medications to lose weight or just lifestyle strategies to lose weight. And as a result of that, their sleep apnea actually gets better. So really, if you can treat, and we've had people who had to do surgery to take out the tonsils or the adenoids and things like that. So if you're able to address the root cause, you might actually be able to reverse your sleep apnea.
Wow. So with that, this is a question which I didn't have in my list, but I am We had a GLP-1 GIP agonist, receptor agonist, recently get approved for obstructive sleep apnea. Any clinical pearls or any form of clinical experience, or have you been using it in clinical practice for your patients?
Yes, yes. I mean, that's one of the first, it's the first and only approved, I would say, weight loss medication for treating sleep apnea in adults with obesity and OSA. So it's not for everybody. You do have to fit that category of being obese. And so it becomes one of the tools we're using. So while I'm talking to someone about using CPAP, I'm also saying this is another modality that we can add. It's a journey. So you're not going to lose the weight overnight. So I would still need you to be on some version of treatments. Well, if that's what you decide for mild, I mean, like if you're moderate or severe, then I'm very insistent on us doing both. But it becomes a tool that we can use. And I've seen significant improvements in weight for a lot of people. And I've seen people who have mild sleep apnea, their sleep apnea gets better when they lose weight. Now, specifically for SEPAM, you to qualify, it's really you need to have what we call moderate sleep apnea, so greater than 15. So typically the insurance pushes back a little bit and getting that us to in getting it approved for those who have mild sleep apnea. But usually if you have an AHI apnea index of 15 and above, we are able to get you on the medication. But I've had significant success with it.
Okay, so a lot of nuances, and I think patients at this time, if they're dealing with, the diagnosis of sleep apnea and trying to figure out with the other weight loss tools and other tools to treat it, it's time to see a sleep medicine specialist because, like you said, it has to be using number of tools to empower them. It can be just one way of treating or one way of preventing this condition. So this was amazing. So almost at the end of our discussion, Dr. Brown, I really wanted you to share pearls of wisdom to our audience in regards to sleep. So it could be sleep time habits, or it could be just some, 5 tips or 10 tips or some strategies to improve their quality of sleep.
Yes, yes. So I would say the first thing is consistency. And actually, research now is showing that sleep timing and sleep regularity is actually more important than total sleep time. So I would rather you have a very regular sleep schedule and a consistent sleep schedule than worry whether you're getting 9 hours of sleep or not. So very important. So you want to be as consistent as possible in terms of your sleep wake up time and your bedtime. That's one. The other thing is you want to have routines that are calming and relaxing that lead you in the direction of the bedroom. So what are you doing before bed? Having that, shower and maybe doing some journaling, some prayers, some podcasts, listening to a podcast. Something that helps you wind down before bed is so helpful. And then your environment needs to be dark. It needs to be cool, at least cooler than the house, and should be noise free. And that will minimize any sleep disruptions. And then you also want to make sure that you are sleeping in bed. You're not using the bed as your office space to watch TV, to eat dinner. And so really protecting your mind such that your brain recognizes that the bed is for sleep and for nothing else. And then finally, I would say the technology piece is big, right? We all know that, being on screens just before bed really can be a major sleep disruptor. So you want to make sure that, again, you're putting the screens away about 30 minutes to 60 minutes before your bedtime.
30 to 15 minutes, and this is for everyone from from infant to a centenarian.
Longer, I think for younger kids, you needed more time. Usually we'll say 60 minutes in kids, but for adults, at least 30 minutes. You want to back up the device use and things.
Yeah, adults, you get some leeway here. Thank you. Thank you. This is amazing because these positive bedtime sleep habits is definitely, upping their game even in their metabolic health, endocrine health, and just quality of life. So it's not just quality of sleep. I feel like there will be so much of transformation, the quality of life, and overall, longevity, health span. So with that, I wanted to share. I don't know if you do this with your practice. I'm pretty sure you might be one of the gynecologists, when we were discussing a fertility specialist, she mentioned that a menstrual cycle is their fifth vital sign because that gets into their questions. Vital signs are pulse, blood pressure, oxygen saturation, and so on. For me, in my practice, I keep sleep as a sixth vital sign as well as bowel movements. What's your take on that?
Movements is interesting. Sleep, definitely. I think sleep is my number one vital sign, right?
So maybe I'll ask a gastroenterologist because I would want to share my insight on that and clinical experience. But yes, now I think whoever is listening, and there'll be a lot of clinicians and physicians also, we should definitely add sleep as an important vital sign for our patients. Yeah, thank you so much, Dr. Brown. If our audience or if anyone listening, watching would want to reach you or get your expertise, how can they contact you or how can they follow you?
Yeah, thank you so much for having me. This was a fun conversation, and thank you for the amazing work you do. Well, you can find me. I think the best place will be on my website, therestfulsleepplace.com. That's where you'll find I have blogs, I have a YouTube channel, I have a book for sleeping children and information about my practice, my clinical practice. I'm licensed in California, in New Jersey, as well as in Pennsylvania. So if you're ever looking for a sleep and wellness expert that can help you really up-level your health overall using sleep as a tool, then we'd be more than happy to do that. And so you could check us out there.
Oh, absolutely. Thank you so much, Dr. Brown.
Thank you.